Welcome, everyone, and happy Pride. It is my pleasure to welcome you today to the HHS Pride Summit panel session. And for those online, welcome back again. We have a packed schedule this morning. For those here in person, please feel free to take a break if needed. We have members of our team ready to assist. Our first panel this morning will discuss sexual and public health in the LGBTQI plus community. Please help me in welcoming Admiral Levine and Panel 1 to the stage.
Well, good morning, everyone. It is really a pleasure to be here for this panel and for HHS Pride, and so happy Pride to everyone. I am Admiral Rachel Levine, and I have the honor of being the Assistant Secretary for Health at the United States Department of Health and Human Services, where you are sitting, and the head of the United States Public Health Service Commission Corps. And so we're going to have a really, really interesting panel. So I have just a couple remarks to begin with. When I see our Pride community, I see hope. Pride to me it represents hope. And that's hope for a more equitable future. I also see bravery, really, in each one of us in our LGBTQIA plus family, for being ourselves despite the challenges that we continue to face in our current environment. I also see strength from love, friendship, and community. And really our theme for Pride this year is that we are stronger together. We are stronger together. Pride is our time to celebrate our community and reflect on how far we have come, but also how much farther we have to go. Pride reminds us that we are a strong and resilient and powerful community that fights hate with love. Pride Month always inspires me. I am in my fourth year as Assistant Secretary for Health, which is really cool. And I am honored to be the first transgender person to receive Senate confirmation and the first transgender person to become a 4-star admiral, which is really, really cool. Thank you. And what I've said over and over again is that my hope, and I think this is going to be true, is that my appointment will pave the way for others to follow in my footsteps so that we will have a future where our leadership is reflective of the people that we serve. Is that I will not be the transgender Assistant Secretary for Health or the transgender admiral. It'll just be admiral. You know, I've often said if I'm the transgender admiral, who's the cisgender 4-star admiral in the Public Health Service? That person doesn't come to work, so we need to call OIG. We are seeing, though, at HHS and across the Biden-Harris administration, a more diverse workforce. With diversity, equity, inclusion, accessibility are celebrated, and we are seeing a future where diverse ways of thinking and diverse ways of overcoming challenges and solving problems are making our world a better place. I am an enormous fan of what has been derided by some, but an enormous fan of DEIA. The Biden-Harris administration promised to support the LGBTQI plus community from the very beginning. And our Secretary Becerra, and myself have joined that promise to promote health equity for all, including our community. Over the past year, we have taken a number of actions and issued numerous final rules to follow through on those commitments. HHS recently clarified that under Section 1557 of the Affordable Care Act, sex discrimination in healthcare includes sexual orientation, gender identity, sex characteristics, and pregnancy. And so that deserves a round of applause. And thank you to Melanie Fontes Rayner and the whole OCR office. A new rule under Section 504 of the Rehabilitation Act presumptively protects people living with HIV from healthcare discrimination. A new rule under the Older Americans Act has designated LGBTQI+ and HIV+ older adults as specific populations of greatest social need. We recently published a new designated placements rule that provides minimum standards for safety for LGBTQI+ youth in the foster care system and protects them from the harms of conversion therapy. Our new grants non-discrimination rule ensures that HHS grantees do not discriminate against people based upon their sexual orientation or gender identity. HHS has completed the first year of the implementation of its Sexual Orientation and Gender Identity Data Action Plan, our SOGI Data Action Plan. And I'd like to thank Adrian Shanker, our Deputy Assistant Secretary for Policy and Legislation at OASH, for that work. In addition, we are working diligently to combat syphilis, prevent mpox, and truly end the HIV epidemic in the United States. Yes, that deserves another round of applause. We are working to address mental health issues in addition to physical health, including LGBTQI+ affirming counselors to the 988 Crisis Lifeline. If you or someone you know is struggling, 988 is available via call, text, or chat. Crisis counselors are available 24/7. They're confidential to support everyone without judgment. And if you select options 3 or text PRIDE to 988, you'll be connected with trained LGBTQI+ trained counselors through the Trevor Project. We are going to continue our work. This Pride Month is really an opportunity to commit to make strengthening ourselves, our communities, and our nation, and to make us stronger. And together we must strongly support the most underserved and marginalized in our community, because we are truly stronger together. Now, I am a positive, optimistic person. You might have guessed that, and it's not subtle. And I choose to be positive and optimistic, because the alternative is despair, and then we can't accomplish anything for the people that we serve. I choose to focus on building a better tomorrow, and I believe that working together we can create a healthier, better future for everyone living in the United States. And we continue to back our words with action and continue to work towards a future where health equity is achieved for all, and we can support our vision at my office at OASH of healthy people, healthy communities, and a healthy nation for all. So I remain hopeful for a more inclusive future because of the work that the people on this panel do and the work that you do every day, because again, we are stronger together. Now, it is fantastic to introduce our distinguished panel. We have Cody Kinsley, who's the Secretary of the North Carolina Department of Health and Human Services. We have Dr. Jonathan Merman, retired Rear Admiral Merman, is the Director of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at CDC. Dr. Dor Hughes is the Acting Chief Medical Officer and Acting Director of the Center for Clinical Standards and Quality at CMS. And Francisco Ruiz, who is our new Director of the White House Office of National AIDS Policy. So let's give them all a hand. Thank you. Well, so I'm going to start with you, Secretary Kinsley. You were quite vocal, and we had several discussions about the importance of changes to the blood donation rules in the United States. So we have worked to change that, working closely and led by the FDA and really many of our divisions, including the CDC and others, to work to change that rule. So what does that mean to you, and what do you think that means to the community in your state of North Carolina?
Well, thank you. It's wonderful to be here. I think back to, like 14 years ago, I was sitting out there listening to a panel, and so to kind of jump here, just 14 years, is pretty inspiring and wonderful for me, and it's a moment. So I grew up donating blood. I grew up organizing blood donations at my high school, and perhaps like many folks, I had had conversations over the years where individuals would invite me to come donate blood after I came out, and I would have the conversation with them, well, actually, I can't donate blood. And they would have the kind of visceral, oh, something's wrong. And, and it was a kind of like a coming out moment. I mean, at that point, people knew I was openly gay man, but they didn't know about the rules and the exclusion. And I'd use those moments to educate. And almost inevitably, people would be, well, that doesn't make any sense. Why is it still that way? And so there was just a kind of a personal affront there. And so I'm so deeply grateful to you, Admiral Levine, who also championed this issue and took it on and joined really the chorus from the American Medical Association, a number of other folks. And I have to particularly thank Dr. Peter Marks and his entire team at the FDA, who just frankly relentlessly went after pushing this policy forward. And to me, it is really a triple win. It is, we need to have a robust blood supply. There's no replacement. Whether you are in a car accident or you have cancer and you need blood, there is no substitute. And so we need as many people to be able to donate as possible. And when we exclude people for kind of dated reasons that are really rooted in kind of a historical stigma, even while the science had evolved, but when we continue to exclude folks, it creates a second class, right? It's the embodiment of stigma. And so you kind of invite those folks to the table of generosity, right? If you have something that has no replacement for which they can then donate, and being able to change the policies to do that is such the right thing. And I think, to me, it is the perfect example of how we have to approach every policy that we have and every practice that we have in the healthcare space, which is how do we really understand the nuance? How do we segment out behavior from identity? How do we have those conversations? And to me, that is what intersectionality is, right? The intersectionality of our human experience, the intersection of our policy creation. It's harder. And it's hard to bring everybody along, but it is the right thing to do. And I'm grateful that under the Biden administration, we're able to finally take that big leap forward. And we'll continue to learn and develop and evolve beyond that as we think about donations of other forms.
Thank you very much. And I want to also emphasize our thanks to Dr. Peter Marks and everyone at FDA for their fantastic work on this issue over years, as well as you, Dr. Merman, who had worked very closely with the FDA on this over years. So let's go to you. Now, CDC has been working diligently on innovative strategies to prevent HIV, including an exciting pilot project on at-home HIV testing. Can you tell us more about that?
Well, I'd love to, but I have to start by thanking you, Admiral Levine and Adrian Schenker, for inviting me and for really being the public health leaders of Pride in the nation. And we, are continually faced with taking a day of celebration and joy and talking about illness and disease. So we're the Debbie Downers of the day. And I wanted to say that there are always disparities in health. And in our case, some of the largest ones exist with HIV and STIs, where gay and bisexual men and other MSM and transgender women are over 100 times more likely to have HIV than others, and 60 times more likely to have syphilis. And we are kind of confronted by this challenge, but we've also been able to overcome some of that and to rise to the occasion with some of the optimism and thoughtful response that you highlighted. So in this context right now, the LGBTQI plus community is dealing with a backlash of racism, homophobia, transphobia, the politicization of HIV prevention and programs, and I think genuine threats to HIV and STI funding, and to some extent a shift in the mood of the country. Yet, the community rose to the occasion. So last month, CDC published data regarding HIV that really did show a strong spoonful of hope. And I did want to touch on that. So between 2018 and 2022, there was a 12% reduction in the number of new HIV infections in the nation. That's thousands of people who didn't get HIV. There was a 30% drop in HIV incidence among persons under 24 years of age, including gay and bisexual men, who account for about 80% of the new infections in that age group. And the reductions didn't occur everywhere in the nation, nor in every population, but some of the largest changes we've seen are among the most impacted people. For example, a decade ago, the group with the highest incidence of HIV were African-American gay and bisexual men under the age of 24. But the community and the public health system responded, and by 2022, incidence had decreased by 50%, and young black gay and bisexual men are no longer the group with the highest number of new infections. We also reported the lowest number of HIV-related deaths in 30 years, about 4,243. Each is a preventable tragedy, but a small proportion of the 1.2 million people who live with HIV in the country. So it's a sign that, that when we embrace innovation, have attention and resources, we can have very positive results. So several years ago, well before COVID, CDC worked with Emory on some randomized trials sending people HIV tests through the internet. And this is primarily focused on gay and bisexual men and transgender women because that was where so many people had HIV and didn't know it. And what we found in those initial studies is, first, people can accurately test themselves. You had to show that. Second, that people were able to get linked to care, even though they were testing themselves in their own home. Third, there weren't negative behavioral implications. People kept saying, well, wait, people are going to start having sex with people and in a way that's going to get them HIV instead of prevent it. That wasn't the case. And then lastly, we did some economic analyses to show it was massively cost-saving to the healthcare system and to society. And so we took that and went to the next step. As you said, a pilot program that started to, people could order the tests, and we were able to find that the populations most at risk, particularly racial and ethnic minorities, and gay and bisexual men and transgender women, were able to access the tests. The majority of the tests are being used by these populations. And we've actually sent over 500,000 tests up to today. So we see it as now a component of productive public health.
Well, thank you very much, and thank you for your work and your division's work and all of CDC's work for years and years, and now, and of course in the future, on this absolutely critically important public health effort. And thank you for your innovation and creativity. So I've been neglecting this side of the podium, so we're going to go over here, and we're going to start with you, Dr. Hughes. CMS has made great strides by adding sexual orientation and gender identity into HHH.gov's enrollment application this year. You have done similarly with Medicare's Part C and D. Can you share more about what CMS is doing to ensure data equity for LGBTQI plus people? Yep.
Safe, Ron, yes. And I also want to start by thanking you for inviting CMS to participate in this panel, and I'm proud to represent on behalf of CMS today. I'd like to start with a simple stat. Across our Medicare, Medicaid, and Marketplace populations, CMS covers nearly 1 in 2 Americans. And so that is just extraordinary when you think of the impact that we can have if we act in concert to improve the health of all of our beneficiaries. But for us, we are especially focused as our #1 strategic pillar on those that have been traditionally underserved, underheard, and of course that includes LGBTQ populations. And so as part of that, when we thought about how are we going to operationalize our health equity agenda, we set out a framework in 2022, a 10-year framework, and the very first area of focus was on data. And for us, we had to take the first step and take the hard look internally. What data do we have? What data are we collecting? And therefore, what data are we using? And not surprisingly, there were some pretty significant gaps, including for those populations defined by sexual orientation and gender identity. And so we had to think about how are we going to increase the availability of data that we need to ensure that our beneficiaries are getting appropriate access, they are getting the coverage they need, they're getting the quality of care that they need. And so we added questions to the applications, as Admiral Levine just mentioned. We also included for states, they had the option, not required, but had the options for them too, to add to their applications for Medicaid and CHIP questions, socio-demographic questions, including about sexual orientation, gender identity. But it doesn't just stop with the applications. Across each of the centers at CMS, we've taken steps. If we focus on the CMS Innovation Center, for any participants in our models, which are the large-scale research demonstrations, we're asking, and in some cases requiring participants to collect data on the beneficiaries they serve, to look for disparities, and if there are any disparities found, to design interventions that can address the disparities. If we look across at CCSQ, the Center for Clinical Standards and Quality, in our quality and payment reporting programs, we have a health equity structural measure that, again, is requiring hospitals to collect data, to use the data, to look for disparities and seeing if there are any inequities in their performance. And as another example, my colleagues in the CMS Office of Minority Health, they prepared a resource, a technical resource document that actually was just released last month, really going through to say, if you're collecting the data, here are the various definitions, here are the standards, here's how CMS is doing it if you want to harmonize with us. But we understand there's reasons that you may have to address it a different way. So here are some suggestions, here are recommendations, and if you find differences, these may explain why you're seeing differences in your results versus your others or other stakeholders in the field. So we're pretty excited. We're, again, just starting over the last 1 to 2 years, but we do think that over the next 5 to 10 years, we will finally have the robust data that we need on populations, again, defined by sexual orientation, gender identity, to make sure that all of our interventions, all of our steps that we're taking at CMS is meaningfully providing access to high quality care across all of our beneficiary groups.
Well, thank you very much, of course, for CMS's continuing work on this issue, but for highlighting CMS and its importance, which is critically important, but then also the importance of data. I mean, there are those who have sought to erase us, to make us invisible, but data is absolutely key to programs throughout HHS and really throughout the administration and the federal government to be able to highlight the needs for the LGBTQI plus community. And so data is absolutely critical. So thank you very much. Francisco Ruiz, congratulations on your appointment as Director of the Office of National AIDS Policy. Let's give him a round of applause. So thank you for joining us today. What are your now top 3 priorities that you're pushing for as we collectively work to implement the National HIV/AIDS Strategy? And how can our community partners work with us to truly end the HIV epidemic in the United States?
Well, first of all, thank you so much for having me. And if nothing else, this panel right here, the diversity in this panel of lived experiences, but also expertise is really humbling to be here and to see everyone in the audience, because I too was in the audience a few years ago, so it's great to be here. And so, as many of you know, the National HIV Strategy, the Biden and Harris administration released in 2021 the new National HIV/AIDS Strategy that takes us actually till next year. And so, in that strategy, many of you know there's sort of 4 areas of focus. Reducing new HIV infections, improving health outcomes for people with HIV, reducing health disparities, and then as well as coordinating across government and across their response. And so these past 7 weeks, I have been meeting with a lot of my federal colleagues on this panel, as well as others who are not here with us today, engaging with national partners and organizations, as well as people with HIV, the communities that we're trying to serve. And so in that, to sort of push forward the strategy, I've sort of organized it in sort of 3 sort of buckets, if you will, and this is sort of the debut of that bucket. And so this is my vision of love. I'm going to channel Mariah Carey, her debut song. This is a queer space after all, right? And so my vision of love for our community. And so the first one is really, the secretary hit on this, is really updating our policies based on science. So we've seen some progress. We've talked about some of that progress already. We have much more to go. And so looking at our employment policies, we've seen some progress there as well, but there's still more room to grow. We know that there's some work we need to do around organ transplant and clinical trial guidelines. And so making sure that people with HIV are also part of that and have access to that science and medicine. We also know that there's a lot of HIV criminalization happening around the country, and we've seen some positive momentum in Tennessee with the Department of Justice going into agreement. And so continuing some of that momentum and looking at our policies, because it's more than just an oral swab or medicine, right? It's about how we live this life that is beautiful and prideful. So that's sort of the first bucket. The second one is really sort of to the initial question is how do we sort of continue the momentum around HIV efforts in this country? It's re-engaging organizations that maybe haven't historically been in HIV organizations but have the eyes, ears, and the hearts of our communities. And so working with our non-traditional partners, our faith-based group organizations, our Black and Latina queer organizations, as well as looking at our data. We talked about that, making sure that we could speak the stories, the impact stories of the work that has been happening to make sure we continue to have champions across the country and on the Hill in HIV. And there's a lot of other sort of elements regarding the strategy that I could go further, but I have a couple minutes. And then the third sort of bucket area is really equity, looking at equity and access. And so really being unapologetic about that, making sure that folks have access to long-acting IRT, PrEP, all the science and medicine that we have to our disposal, making sure that everyone has that. You know, this is a race. We need to make sure that everyone is invited to the race, has the equipment to run effectively in the race, but also has, and this is the part around sort of making sure folks are at the table, also can sort of help define the course that we're going to do in this race so that we're all at the finish line together. And so I'm really excited about that, and I could go on and on and on, but I'll pause there because I know you have some follow-up questions.
Thank you very much. And thank you for highlighting the health equity component. You know, we have what in the 1980s I would have considered medical miracles in terms of PrEP and in terms of ART and U equals U, but we still struggle to get those medical miracles to the people who need them most. And so thank you. We're looking forward to working with you. So I'm going to switch back over here so you don't feel neglected. I'm going to go to Dr. Merman. So, you know, we are working together on many different things, including STI prevention and treatment, sexually transmitted infection, including syphilis. So we often say that now because with the task force that we have, that we are all syphilis all the time, but I don't know if that's the right message. But anyway, so we are really trying to address the syphilis crisis in the United States, but other STIs as well. So can you highlight some of the prevention and treatment work and strategies that you're working on at the CDC and our collaborations with the task force?
Thank you, Admiral Levine. I would be rife if I didn't kind of talk for a moment about how the STI epidemics have been growing over the past decade. We've had over a 10-fold increase in syphilis and gonorrhea over the past decade, and that's presented a great challenge. At the same time, it's happening in the context of the COVID epidemic. And trust is a gift that should be nurtured over time. But our nation continues to suffer from COVID, not only because over 1 million Americans died and infections continue, but because it caused distrust in institutions and people. And we are polarized. And this has resulted in increased skepticism of the traditionally trusted HHS institutions such as the FDA and NIH and CDC, the very ones that are involved in the response to HIV and STIs and whose success requires trust. So I'm reminded that Bayard Rustin said that the proof that one truly believes is in action. And tomorrow, CDC plans to publish our final guidelines on doxycycline post-exposure prophylaxis. And this has been an effort of many months. There have been 3 randomized controlled trials that have looked at the efficacy of taking 1 dose of 200 milligrams of doxycycline, a 60-year-old antibiotic that's being used differently, and following sex. So 1 dose within 72 hours of having sex, and in those 3 trials, collectively, they've shown about a 2/3 reduction in the acquisition of syphilis, gonorrhea, and chlamydia. There are, should I stop?
I think we should,
Cody?
yes, we should give that a round of applause. This is one of the newest innovations in terms of treatment, prevention of sexually transmitted infections, including, again, the syphilis, which has been plaguing our country. So
Right.
thank you.
No, thank you, and we need to proceed enthusiastically and cautiously. There are still some questions. Our recommendations, because of the data were in these populations where it was shown to be successful, are for counseling by providers for gay and bisexual and other MSM and transgender women who have been diagnosed with an STI in the past year. And we want to normalize that discussion so it just becomes what we do. But there are new studies that will be implemented soon by a sister agency that will look at its use in other populations, it may be timing differently, and also to monitor things like antimicrobial resistance and potentially the effects on the microbiome, because we really haven't used a medication this way. In the studies, the average number of times a month that the participants used doxycycline was 4. So it's not every day, like taking doxycycline every day to prevent acne, which has been used for years, but it's also not just a one-time event like we would use it to prevent Lyme disease after a tick bite. So it's something different. So I think that like the collective scientific and policy and public health infrastructure needs to examine this, but this is the most exciting intervention to prevent STIs since the human papilloma virus vaccine. And I wanted to say that we at CDC are very excited to have a new tool in these difficult times.
Well, thank you very much. We're looking forward to your announcement tomorrow. So I'm going to shift over here and go back to Dr. Hughes. So we've been talking about HIV, and ensuring access to care and coverage is critical. Can you talk about CMS's role?
Yes, and it's very exciting. I'm quite looking forward to the announcement. So Dr. Levine described PrEP as medical miracles. I'm going to take that back to CMS. We were excited last year. CMS announced a proposal that we would cover HIV PrEP through a national coverage determination, both the oral and the injectable, is through Medicare Part B, and therefore beneficiaries who are using PrEP would be able to do so without any cost sharing. And so that is, we are working hard to finalize that, but also importantly, and this touches on what Dr. Merman was noting, that it's not enough just to have HIV PrEP. You really need the counseling, and as part of the proposal last year, we've also proposed that there would be 7 counseling sessions, that there would be additional HIV screening, there would also be screening for hepatitis B, and again, all without cost sharing, and we think that if we are able to propose this national coverage determination, then that would be a significant step forward certainly for our agency, but more importantly for the beneficiaries that we serve. But we know that HIV PrEP is excited. I was like, it's hard to say it's not enough when you describe it as a miracle. But we're also thinking about what else can we do that really will tackle this epidemic. And in some of the cases, CMS has put out through our Medicare Learning Network trainings for our providers, specifically caring for LGBTQ individuals. We know that it's extremely important to be in a trusted relationship. That if you are going to, A, go see a provider, but B, get appropriate culturally responsive care. We are also thinking about ways that we can promote telehealth as another example. We know that many of our beneficiaries are living in areas that without easy access to providers that they'll trust, providers who are experienced and appropriately caring, and so telehealth may be a better option. And not only for their experience of care, but actually for the clinical care provided and the outcomes. And so doubling down on telehealth flexibility is another priority for us. We are also thinking through how can we expand treatments. Mental health treatment is another example, integrating that with primary care. We're also being very systematic and deliberate in trying to form more partnerships with community-based organizations, advocacy groups that can, again, help to inform our interventions, our decision-making, but also link beneficiaries to the care that they need. And as already mentioned, we are trying to make sure there's no sunlight between CMS and the HHS Office of Civil Rights in enforcing the anti-discrimination requirements. We've put out guidance specific to, again, those populations defined by sexual orientation and gender identity. So it's a lot. We're trying to do as much as we can to, again, meaningfully help to address this epidemic. Appreciate always all of the input and guidance that we receive from so many of you, as well as certainly our federal agency partners.
Thank you so much. So we're getting closer to our time, but I have 2 more questions, one for you and one for you, so just in terms of time. So in terms of your work in North Carolina on HIV and on STIs and syphilis, can you tell us some about how you're working, I know, very closely with CDC and others on these issues?
So I think what's important, and perhaps this is like me being from the South, is, we're talking about how do we have these novel breakthroughs and new therapies and new prevention strategies? How do we make sure that they're covered? And I so appreciated your point about but how do you actually get people to the table of access? And for me in North Carolina, the answer is always food. And what I mean by that is, we've got this pilot, thanks to our friends at CMS, where we are, piloting the use of Medicaid dollars to pay for food and food boxes, and it's showing reduced hospitalizations, reduced emergency department visits in some of our most rural and underserved communities. And the community-based organizations that are doing that work, that are now getting funded through Medicaid to do it, 75% of which are minority or women-owned. And that is the space where we are building trust, because friends, the LGBT community in North Carolina, 35%, in a recent study that Duke put out, 35% of them showed to be food insecure. 48% of them with a household income below $24,000. Of course, Medicaid expansion is also important too. We've already seen since December 1 to May 24th, just among our Medicaid expansion population in North Carolina, 5,000 claims for HIV medication. So, I think my challenge to us all is, how do we think about the whole person? And how do we bring, I have a Department of Health and Human Services, this is a Department of Health and Human Services, how do we bring the health and the human together? And I think the challenge, and I think you're seeing it come out in this panel, is the commitment to thinking outside of our silos and our normal operating lanes. And that's how, through the trust of the food boxes, is then the next conversation is, how do you actually, and the coverage of expansion is, how do you get access to those point-in-care or point-in-time rapid tests for syphilis? And then how does that get you into the slippery slope or slip and slide to then actually having connections to healthcare through telehealth, et cetera. But it's how do we bring all those pieces together? And for us in North Carolina, it's food.
Thank you. Thank you. Now, you're going to bring us home. In terms of some of the things that you're working on, I know that quality of life measures are critical for people living with HIV, ensuring people live and age with HIV, have access to quality care. Can you talk about your vision for that?
Definitely. And so the administration's strategy now includes the quality of life. So we know that it's more than just a medicine. So it's about making sure that folks have their mental and emotional health. They have physical health, as well as the other sort of structural dimensions that impact their health. And so I think regarding people aging with HIV, we also know that about 55% of people with HIV are over the age of 50, and that number is only growing. And so I think we need to really put some focus there. As I approach the 50 mark, I'm not there yet, but I'm almost, making sure that the services in our country are serving our community. And so I think one of that is making sure that the institutions and the agencies and the services that we have for people aging also include the conditions and needs of people with HIV. I think making sure that we have those tailored policies as well as the funding mechanisms to sort of do the work. I think the collaboration with providers, with community-based organizations, as well as people living with HIV, to make sure that the resources are there. And so I think there's a lot of collaboration and coordination that needs to happen, sort of in the spirit of making sure we bring back the humanity of this work. It's not just about a pill, as I said before. It's how do we serve the whole person. And as we age with HIV, there's a lot more needs that we need in terms of health conditions. How do we sort of serve them?
Well, thank you very much. What a great panel. So thank you. Thank you. So I want to close by encouraging everyone to also prioritize your own health during Pride, your own physical and mental health. For example, if you smoke, quit smoking, get routine testing, keep up with preventative cancer screenings, make sure you get your immunizations. In terms of mental health, just to highlight SAMHSA's 988 program, we all do fantastic work at HHS and state and local health officials as well in terms of public health. And we don't always realize the impact that we make, but we do through all of our actions, big and small. So in summary, again, we are a strong and resilient community that fights hate with love, and we are stronger together. So one quick question, what does Pride mean to you, Dr. Merman?
Well, so people who know me know that reducing to one word is tough.
You've already
but I would
not
say
done that.
My one word is love.
Love. I love that.
Whole.
Whole. Please.
Joy.
Inclusivity.
Thank you. Mine is hope. Hope for the future. Thank you very much.
Hi, everyone. We're about to start panel 2. It's an honor to be with you all today. My name is Brian Kaplan. I'm Senior Advisor in the Office of the Secretary, where I serve as advisor on LGBTQI+ issues. I work closely with Lee Stevens, the incredible mastermind behind the summit, and with Adrian Schenker in the Office of the Secretary, who many of you all know, who's really the mastermind behind a lot of our policy work, and the community engagement that's so key to advancing the LGBTQI+ community's massive wins in the Biden-Harris administration. So once more, on behalf of the Secretary, I want to give a shout out to our intergovernmental and external affairs partners for putting such a great day together. Thank you for bringing us together today, and thank you to you all for joining us and kicking off Pride Month. We're very excited for the rest of the month. I am particularly proud of this coming panel because of the chance to stop and reflect on all of the incredible work that we've done in the past few years. In the face of significant headwinds and relentless attacks, we've been able to enact the most pro-LGBTQI+ agenda in history. It's not often that we have a chance to stop and really feel that. This coming panel is moderated by Adrian Schenker, the driving force behind that work, and as we like to joke, he's also my work wife. He's my first call in the morning and my last call at night, and we are definitely kept busy by this incredible portfolio. This panel also features some of the incredible leaders of this administration who, among many other things, are fighting to cement civil rights protections for healthcare access, protecting LGBTQI+ kids in the foster care system, and ensuring that our LGBTQI+ elders are able to thrive and lead comfortable and open lives as they grow older. And we also have one of the administration's strongest voices on the global front, Special Envoy Stern, who fights for the rights of our community all around the world every day. All right, please help me welcome to the stage Jenny Ma, Principal Deputy Director of the HHS Office for Civil Rights. Jeff Hild, Principal Deputy Assistant Secretary for Children and Families, performing the delegable duties of the Assistant Secretary. It's a long one. Allison Barkoff, Principal Deputy Administrator of the Administration of Community Living, performing the delegable duties of the Administrator. Jessica Stern, the U.S. Special Envoy to advance the human rights of LGBTQI+ persons. And finally, our moderator, Adrian Schenker, Senior Advisor for LGBTQI+ Equity and Acting Deputy Assistant Secretary for Health Policy. Thank you all so much.
Good morning, and welcome to our HHS Pride Summit. We're so happy that you're all here. And thank you to our panelists for taking time today to join for this important session, which we're really going to be lifting up some of the wins that we've had at HHS in terms of LGBTQI+ equity, some of which are interagency wins that Special Envoy Stern will highlight as well. But we're really proud of this work to advance LGBTQI+ equity in our health and our human services. Without our health, we don't have our lives. This is so central to our lived experiences in the world as queer, trans, intersex people. And there were some papers that you all got when you come in, and they included some of the highlights of some of the accomplishments at HHS. One of them is a highlight on the SOGI Data Action Plan, our Sexual Orientation, Gender Identity Action Plan, and the first year impact of that. And it's been pretty impressive that every single one of our HHS divisions has done a thorough review of every data instrument that they have to make a data determination about how and if they're able to add in sexual orientation, gender identity. Data equity is about being seen and being heard in federal surveys, but it's also about ensuring we can put resources where they're needed most based on disparities. You also received an info sheet about the general HHS wins that included a lot of our rulemaking as well as non-regulatory pieces, and our panelists will speak to some of those. And then you also saw a one-pager from CDC about ACEs, adverse childhood experiences, and you're the first to see it. CDC today has provided this fact sheet to update the definition of ACEs to include LGBTQ discrimination that youth face, and that's super important for understanding what it takes for youth to thrive, for LGBTQ youth to thrive. In that fact sheet, it also talks about positive childhood experiences, that if LGBTQ youth experience it, they'll develop the resiliency factors to be able to thrive. So there's more information on the fact sheet there, but really happy about that. And we'll talk today about our rulemaking as well as some of our work on our global interagency action plan on conversion therapy. So first, I'm going to start with Jenny Ma, our Principal Deputy Director of the Office for Civil Rights. Jenny, OCR recently issued a brand new 1557 rule. Congratulations and thank you. Provides essential civil rights protections for LGBTQI plus people in healthcare. Can you share what this means in terms of the recourse available for people if they feel that they've experienced discrimination?
Sure. First of all, thank you so much, Adrian, and all of my fellow panelists, and all of you here in person and online. It's very meaningful to see folks experience so much joy to kick off Pride Month and to have this be here in the Great Hall of HHS for the second time. So happy Pride Summit. It's very meaningful, and it's a joyous day. So I'm Jenny Ma, use she, her pronouns. I work at OCR, which is the Office for Civil Rights. I know some of you are very familiar with our office, some of you may not be, and some of you may be very familiar with Section 50 and 57, and some of you may not be as well. So I'm just going to do a little bit of level setting. This is the non-discrimination provision. It's the kitchen sink. It encompasses many different types of stakeholders and issues, ranging from AI, LGBTQI rights, insurance, and it runs the gambit. But most importantly, it is the third iteration, about a month and a few days now. OCR issued the final 1557 rule. We're really excited. This is an endeavor of love and just care for, I think, 1.5 to 2 years of really hard work by Director Fontes Rayner, as well as our team at OCR, going through, as you guys know, looking around this room, I see some familiar faces who pushed us and advocated and wrote comments, and we are so thrilled to have it see the light of day and to have it be out there. Specifically, with regards to the LGBTQI community, the rule takes certain, the former administration had severely restricted what sex discrimination means. And what this rule does now is reinstates in a robust form what sex discrimination means. We are armed with, of course, recent case law, including the Supreme Court's decision in Bostock. So we incorporate that into the rule to ensure that sexual orientation and gender identity are included in the definition of sex discrimination, so that no one experiences discrimination without recourse based on their LGBTQI status. And we make sure that there is recognition of queer folks, trans folks, intersex folks when they get health care, and that, again, to answer Adrian's specific question, part of the work that we do is in the policymaking space. So now you've seen the reg. I'm sure you all have read the 600 plus pages of it. But now you guys get to do the work, right? We are going to be out there talking about this rule and educating folks about what's in it. We have a newly revamped 1557 website, which is, a government website, so please give us grace. It's not the sexiest thing in the world. But it's HHS.gov/1557. There's lots of fact sheets. There's summaries of what the rule encompasses, both on our issues as well as the other issues I talked about, because this rule also recognizes that there is intersectional issues, right? You can be discriminated both on the basis of your sexual orientation, but also on your race, color, national origin, disability status, and age. And so we are going out there, as we have been, to talk about 1557, but we also need real life experiences from you all, and who you serve and the communities that you serve and what you're seeing on the ground. OCR is also an enforcement agency, so that means when we hear about something, we can open a compliance review, but you all can be empowered to go to our website and submit a complaint through our complaint portal. In October, it was recently revamped to make sure that it's available and more accessible to folks. It's now available in 15 plus languages, including English. It includes pronouns, and it also has different honorifics, including MEX. to reflect the realities. And there's a pull down for sexual orientation now, which also reflects sexual orientation and gender identity. So it's really important to hear from you all on what you're seeing. And I just want to emphasize the purpose of it. I know enforcement agency sounds kind of scary, is not to be necessarily punitive. We certainly will be if necessary, but it is also to make sure that if someone is discriminated, we hear about it, we investigate it, and that we make sure that there's recourses available. And that could be as simple as training the individual person. It can be as robust as making sure that the entity has new policies and procedures. But we are hopeful that this rule will make both incremental and large changes, and we are so excited to have it see the light of day and the incredible work that went into it and all of the red lines and everything. So we're super excited, and now leave it to your all's capable hands.
Thanks, Jenny. We'll next go to Acting Assistant Secretary Jeff Hild. ACF's final rule on designated placements provides critical protections for LGBTQI+ youth in the foster system. Please share a little bit about what this means for foster kids and their families.
Thanks, Adrian. It's great to share the stage with my other panelists, and we're also equally excited about the 1557 rule as it covers many of our programs at ACF. So I'm Jeff Hild. I get to lead the Administration for Children and Families. I use he, him, his pronouns. And I'll just give you a little context about where we started on this rule, which is we started by listening. What we did is brought in former foster youth to tell us about their experiences in the foster care system. LGBTQI, 2S+ youth, some of whom had gone through dozens of placements in their lives, so talk about compounding trauma. We listened to parents of trans kids in Texas about their experiences. We listened to affirming caregivers in Texas and other states about their experiences, and that really formed the basis of what we did in this rule. So a little bit about what the rule does. So first, it clarifies that no foster care placement may engage in actions that would amount to harassment, mistreatment, or abuse of kids. And this includes so-called conversion therapy and other efforts to suppress or change a child's gender identity. Second, the rule requires states to ensure they have a sufficient supply of foster care placements that are committed to and trained to meet the specific needs of LGBTQI 2S+ kids. The rule calls these designated placements, and it emphasizes that kin and relatives should be offered services and supports to help them serve this role whenever possible. One of the things we want to do is build a kinship-first foster care system, and we know that sometimes those families need tools around acceptance, and part of what the rule does is acknowledge that. The rule also protects children and their adult caregivers from retaliation for requesting or participating in services that affirm their identity. So we have now clearly told states that federally funded child welfare agencies cannot accuse these parents of child abuse simply for supporting their kids. This is a huge change for us, and I think an important marker for this administration for protecting children in the foster care system and their families. So as Jenny said, all of these rules are a labor of love with lots of different twists and turns in the process. And I think now that this is out in the world, we need your all's help in telling us what's happening on the ground. We need your help in helping to hold states accountable for following this rule. And we need your help to know what's next. What's the next thing we need to be doing to protect children, to protect families, to affirm children's identities, and make sure that every child, no matter their sexual orientation, no matter their gender identity, no matter their family status, has a chance to thrive and be well in this country. And that's what we're aiming to do with this rule. Thanks.
And we'll next go to Allison Barkoff, our acting administrator of the Administration for Community Living. ACL's final rule on the Older Americans Act designated LGBTQI+ and HIV-positive older adults as populations of greatest social need. What does this mean for LGBTQI+ and HIV-positive folks as they age?
Thanks so much, Adrienne, and I'm really thrilled to be here. Glad to see so many stakeholders here in person and online. And I really want to start with a thank you, because one unique thing about ACL is we are an agency that really has a mission around advocacy, and we can't do it if we're not engaging with stakeholders, and so many of you across the room have really helped us with our policies. For those of you who aren't familiar with ACL, we're the agency that focuses on aging and disability programs across the country, and we serve as the advisor to the Secretary on aging and disability policy. And really, the guiding principle of our agency is that all people have a right to live where they want, with the people that they choose, and to fully participate in their communities. And for many disabled people and older adults to do that, they have to be able to access services and supports. And unfortunately, we know that there is not equal access to services and supports. I want to do a shout out as a longtime civil rights lawyer and as ACL working closely with OCR on Section 1557 as well as Section 504, that we have really important civil rights tools. But we also really need to think about the programmatic tools that we have. And for older adults, many LGBTQIA+ older adults have long faced discrimination and barriers to accessing care. And I just want to give a few sobering statistics in the health disparities that older adults experience. They're more likely than their non-LGBTQ peers to be economically insecure, lack stable housing, and be food insecure. Despite having higher incidence of disabilities, anxiety, and depression, they are more likely to avoid accessing long-term services and supports, therapy, and counseling because of fear of discrimination. They're nearly twice as likely to be living alone with inadequate family or social supports, so more likely to be socially isolated. And now the vast majority of people who are HIV positive are older adults. So at ACL, we are really fortunate. We implement the Older Americans Act and the incredible programs that help older adults age in place. Things like home-delivered meals, congregate meals in senior centers, in-home supports, supports for family caregivers, health prevention, and chronic disease self-management programs. And in our statute, equity is the centerpiece. The statute specifically directs that we have to prioritize older adults who are in the greatest economic and social need. So as we, for the first time in more than 30 years, decided to update our regulations, it was a priority for us to be clear about who we meant when we talked about people in the greatest social need. And we are so proud that our regulations specifically call out LGBTQIA+ older adults and older adults who are HIV positive. I think sitting in this chair, a chair that is time limited as an appointee, we think very hard about durability of our policies. And I think that's why you're hearing from all of us about the work that we have done to really cement in equity into our work. Adrienne also mentioned the work that we have all been doing around data collection, because if we can't see who we are reaching in our programs and our data, then we aren't doing all that we can. So I'm really proud that ACL, we are small but mighty, and we have truly been the way leaders, leaning in very hard in adding SOGI data collection to every single one of our aging and disability programs. And I really appreciate the stakeholders who have been working with us on that really important work. So we are really proud at the work that we're doing to help older adults, particularly those who have long experienced discrimination or been socially isolated, to be seen, to be welcomed, and to be really able to access ACL's programs.
Thank you, Allison. And before we move to global policy, I just want to acknowledge that all of our divisions at HHS have really been doing incredible work in LGBTQI plus equity. These three divisions in particular, the principals who are here have been strong champions, and our OCR director, who's not able to be here, Melanie Fontes Rayner, the three of them have really been incredible champions for LGBTQI plus equity at HHS. And we're so lucky to have you here. We're also really lucky to have Special Envoy Jessica Stern, who is one of our interagency partners, especially in our work to advance safety and well-being for LGBTQI plus youth around the world, and to keep youth safe from the harms of conversion therapy. HHS and state have worked collaboratively on a global interagency action plan to combat conversion therapy. Special Envoy Stern, would you share a little bit about what this looks like in your work as you travel around the globe?
I'm happy to. Can everyone hear me clearly? Great. Well, first of all, happy Pride, everybody. It is, yeah, we can give that a round of applause. We'll be applauding for LGBTQI plus rights all month long. It does not surprise me that HHS is doing the kickoff event for Pride Month. One more example of your leadership on these issues. I'm glad Adrian started by asking a question about conversion therapy practices, because for those of us that work on LGBTQI plus health or marginalized and vulnerable youth, conversion therapy practices are not a new concept to us. I think it has actually been one of those issues that's been like a dirty secret, where we all know someone who's survived conversion therapy practices. Some of us are survivors ourselves. But the lack of data about LGBTQI people and conversion therapy practices and the lack of policy interventions has been a severe problem all around the world. And I'll just give one quick example. I think that when you start looking for instances of conversion therapy practices, you find that they're everywhere. So about a week and a half ago, we had a staff meeting, and a member of our team started doing a sort of routine report about the work she's doing to support LGBTQI asylum seekers and refugees. And she was working on a particularly delicate case that we're putting a lot of energy into. So she wanted to share with us the circumstances of the case. The bottom line is that this woman was a part of an LGBTQI plus organization. The organization became known to the government where she lived. The government intervened, immediately disbanded this organization, and arrested all of its known leaders. This woman, who was a lesbian, fled the country because she was known as the sort of next tier of visible members of the community. She went to a third country trying to seek safety, trying to figure out how to rebuild her life, and unfortunately the authorities in that country found her, and they brought her to her country's embassy and basically said, deal with her. Unfortunately, they did deal with her. What they did was they discovered who she was, they discovered why she had fled her country, and they raped her. And what she told our colleagues is that they raped her to teach her a lesson. They raped her to teach her to be straight. So conversion therapy practices, unfortunately, are more common than we acknowledge. And when we start thinking about how serious they are, it calls for action. So I really like the theme of this panel, Adrian, because it's not just about diagnosing the problems, it's about demonstrating what we've been doing as solutions. Can I see a show of hands? How many people have heard of Executive Order 14075? Okay, I love speaking with a nerdy audience. For those of you that have heard about it, good job reading all of the executive orders. For those of you that are not aware of it, Executive Order 14075 mandates that the Department of Health and Human Services, USAID, the Department of Treasury, and the Department of State increase our efforts to combat conversion therapy practices worldwide. And it's really been a sort of landmark partnership between our agencies. And actually, a year ago, we released an interagency action plan for fighting conversion therapy practices worldwide. And if you haven't seen it, please look on the HHS website. I think it's probably there, and is really a blueprint for what we can be doing to tackle this issue worldwide. What I want to highlight is that although conversion therapy practices are rife around the world, they've also been discredited. So just as no heterosexual person should be made to be gay, no LGBTQI plus person should be forced to be what they are not. Conversion therapy practices has been disavowed by the American Medical Association, the American Psychiatric Association, the American Academy of Pediatrics, the American Psychological Association, and the UN Independent Expert on Sexual Orientation and Gender Identity. So the question is not, do we have clear data saying that these practices are harmful? Because the answer is yes. The question is, what are we doing about it? So I'll give some examples from the perspective of state. When we developed the Interagency Action Plan, one of the first things we realized is our colleagues didn't know what conversion therapy practices were. We actually asked embassies, do you have conversion therapy practices in your country? And they would say, no, we don't, but. And the but was a broad range of practices, from forced starvation, physical assault, prayer circles, et cetera. So the first thing we learned is we actually had to explain what the terminology meant. The second thing we've started to do is to engage foreign governments in trying to stop these practices, to actually explain what the medical experts say about conversion therapy practices and the harms they produce. And what we're trying to do is prevent foreign governments from stopping sponsoring, funding, or otherwise supporting conversion therapy practices. If you read the State Department's Human Rights Report for Malaysia in 2020, you find that in that report, the government of Malaysia actually self-reported on examples of conversion therapy practices that they were performing through their medical system. So it's not just that the practice is rife, it's that there are certain state-sponsored programs, and that's something we really have to take seriously and counter. We're also working in coalition with like-minded governments to counter conversion therapy practices worldwide. And we seem to have a theme on this panel of talking about rules. So to continue that theme, we have a contribution to the rule discussion. We are currently in the public comment period of a new regulation that, if finalized, would ensure that the State Department's grants and contracts would not permit or enable conversion therapy practices. And thereafter, it would ban all such practices for implementing partners, grants, and contractors, and would have a ripple effect across all of the work that they do. And then last but not least, I just want to highlight, it's one thing to know that conversion therapy practices exist. It's another thing for community leaders on the front lines to have the resources to document that conversion therapy practices exist and to be able to fight back. So at State, we're issuing a call for proposals from the Global Equality Fund, and at USAID, the Rainbow Fund is increasing support for LGBTQI advocates on the front lines trying to stop conversion therapy practices. I'll just end by saying this is just the tip of the iceberg in the work that we need to do, but if anyone in the audience is interested in getting involved, there's so much opportunity for impact in this burgeoning and urgent field.
Thank you so much. For the next question, we're just going to be on the brief side for our responses, but we'll go back to Jenny. OCR also finalized a new rule on Section 504 of the Rehabilitation Act, which provides presumptive protections for all people living with HIV. Can you share a little bit about what that looks like in practice?
Sure, and I'll be brief. Section 504 is another one of our labors of love. It advances equity and bolsters protection for people with disabilities. And this rule clarifies and strengthens civil rights protections for people with disabilities. It addresses discrimination in medical treatment. It adds enforceable standards for accessible medical equipment and ensures that there's accessibility in web content and mobile apps, which obviously is increasing in the healthcare space. Among many other changes, this rule hasn't been revised or updated since the 1970s. And if you think about how medical care has changed, how the disability rights advocacy space has changed, how new laws like the Americans with Disabilities Act have come into play, it's long overdue. Specifically, Section 504 protects against discrimination based on a person's HIV status, whether that is real or perceived. And I want to kind of go back to how important it is to hear from you all. Not only were comments submitted to this effect to ensure that HIV status is included in Section 504, but we actually had an enforcement action where a healthcare facility was denying a individual care based on, it's a rehab facility, and based on their perceived HIV status. OCR investigated that complaint. We were able to get remedies based on Section 504, and so that is just like coming full circle to making sure that we hear from you so that these rules actually have bite and effect. And I'll just say one more thing quickly on Section 504. Section 504 also includes gender dysphoria as a basis of discrimination. So and if you are on our complaint portals, we don't expect everyone to know all the laws and the nuances of 1557 or 504, but having gender dysphoria included in Section 504 does give us another arm in which to enforce these laws. So we are really excited, again, that these rules are out there, that they are serving the community, and we look forward to enforcing them.
And some intersex variations are also protected under
Correct.
504 as well.
Correct.
Yes. Jeff, ACF also issued an information memorandum about conversion therapy, specifically for youth in the runaway and homeless youth system. You've done a lot of work to support LGBTQI plus youth who are unsheltered, but speak a little bit about that.
Yeah, happy to. So one of the programs we fund is the Runaway and Homeless Youth Act program. So this serves youth and young people who are experiencing homelessness, and it's no surprise to this room, many of those young people are experiencing homelessness directly as a result of their sexual orientation or gender identity, including many children who aged out of the foster care system. So what we did late last year was issue an information memorandum to all of our RHY grantees that does a few things. First, it confirms that RHY funding cannot be used to cover any treatment or referral to treatment that aims to change someone's sexual orientation, gender identity, or gender expression. And secondly, it affirms that children and youth served by RHY programs are protected from any attempt to disparage, change, or degrade a young person's sexual orientation, gender identity, or expression, regardless of the nature of the intervention or the credentials of the person administering it. So we're extremely proud to have locked in and embedded those protections in our Runaway and Homeless Youth Act programs. If I may, Adrian, the other thing I want to mention while we're on the rule kick is that we also issued a final rule around the unaccompanied children's program. So one of the programs we administer is providing care and shelter for youth who enter the country without a parent or guardian. This is a direct service program for us while we work to place them with a sponsor in the country. And two things that the final rule does is, one is it bars conversion therapy in the UC program by regulation. And the second thing it does is ensures that a young person's placement in our care is affirming of their identity. So these are very important protections for youth, oftentimes who are fleeing violence in their countries of origin, sometimes in regards to their SOGI, as the special envoy mentioned. So we're very proud of these two accomplishments.
Thank you so much. And absolutely, these are some of the most vulnerable youth in the world in terms of discrimination and violence. So that rule, the UC foundational rule, is really, really important. Allison, you recently hosted the department's Lesbian Visibility Week event, where you highlighted caregiving concerns for older lesbians. Can you share a little bit about why caregiver support's important and the work that ACL does to support the caregiving community?
As I talked about, so many people need access to care to fully participate in their communities, but because of challenges, more and more people are relying on family or friends to provide care. We have 53 million caregivers who are unpaid in this country. And supporting caregivers is a top priority for this administration. President Biden put out the first ever care executive order. And if anyone has ever heard Secretary Becerra talk about this topic, he brings such personal passion and commitment as someone who cared for his own father as he was aging. ACL was privileged to lead the first ever development of a national strategy to support family caregivers. And we did that together with more than a dozen federal agencies and an advisory committee made up of a range of caregivers and people receiving care. And this final strategy includes more than 300 commitments, not we might do's, but we are doing, from federal agencies, as well as recommendations for state and local government, businesses, advocates, and for Congress. And a really important thing that we emphasized in this report was looking at equity and recognizing the fact that there are, of course, some commonalities across caregivers, but there are a lot of additional challenges that people might face because of discrimination or barriers in accessing care. And that is particularly true for LGBTQIA+ caregivers, as well as LGBTQIA+ people receiving care. So turning to our roundtable, which was so powerful, I just want to share a couple themes that we heard. As I mentioned, many older LGBTQIA+ older adults do not have family that they can rely on. So they often have to rely on partners or friends for assistance. So we have so many people who are in the LGBTQ community who are caregivers disproportionately. One thing that Adrienne, who was with me, heard, and it was truly heartbreaking to hear from people who really led the way on being out. They feel like they have to go back in the closet, that if they are going to, a senior living center, a nursing home, or even having someone come in their own home, they have to, as they said to us, clean up and, really take away their pride, and it really causes trauma. We heard that literally from almost everyone across the table. And finally, one thing I heard loud and clear as the administrator for Older Americans Act programs is how critical it is that these programs not only welcome people, but be very visible in how they welcome people. So people know these are safe places. We've heard again and again and again how truly life-saving the Older Americans Act programs are, but people need to know that they can come there and be themselves. Finally, I'll just say that this year we were able to launch projects of national significance around caregiving to really start implementing the National Family Caregiver Strategy in communities across the country and in the aging networks. And across each of those initiatives, we are requiring a focus on underserved communities, including LGBTQIA+ communities. And we are just really proud. I will say, we believe all means all. It is really a North Star for ACL. And we cannot be successful if we do not make sure all older adults feel welcomed and feel well served by our programs.
Thank you, Allison. And Jessica, a special envoy, one of the other areas that we work on together is around criminalization of LGBTQI+ and HIV-positive community members. And many in our community have been concerned about what they've read in the news. Can you speak in terms of how, when you're going around the world talking about the human rights of LGBTQI+ people, what does it look like in terms of access to healthcare services for LGBTQI+ people, people seeking HIV prevention or treatment services in light of criminalization?
You wanted to give me the depressing question to end on. We're a group of people that care. That's why we're in this session right now. So I want to show respect for everyone here and be honest and say, it is a very difficult situation, Adrienne. You read the news, you know that there's an increased backlash against LGBTQI plus people around the world. You know, it sometimes feels like 2 steps forward, 1 step back, sometimes in the same moment. But as we've seen LGBTQI people have increasing success in securing our rights and our dignity, there's been this tidal wave of backlash. And it sometimes feels like the backlash is stronger and faster than our ability to secure our rights. So I will say I'm an optimist, and it's June 1st, and we're going to carry the good energy of today throughout the month and year, but it's a hard time to be doing this work, and Adrienne is absolutely right to ask about the impact of criminalization on LGBTQI plus health. I want to use the example of Uganda because I think that's one people in this room have probably read about and heard about. You're probably aware that Uganda passed the Anti-Homosexuality Act, which at the time was one of the most far-reaching, extreme, and dangerous anti-LGBTQI plus laws in the world. Just to be clear, Uganda is not the first country in the world to have anti-LGBTQI laws on the books. There is not a country on the planet that has a perfect record on LGBTQI rights. But the reason we talk so much about the AHA is because it was sort of this novel new package that criminalized LGBTQI people in a 360-degree way. It enhanced criminal punishments for LGBTQI people, so-called serial offenders, for so-called aggravated homosexuality, to life imprisonment or death. It created mandatory reporting. So if you suspected someone of being a member of the LGBTQI plus community, you could be held criminally liable if you didn't report them. And it effectively banned LGBTQI plus organizations and silenced freedom of speech, assembly, and association about LGBTQI plus rights. So in this context, how do you imagine that LGBTQI people would have equal, equitable, or appropriate access to health care? Just for a moment, imagine what it's like to be a butch lesbian going to get a new prescription for your eyeglasses. Does your doctor have to report you? Imagine that you're a effeminate gay man and you have a toothache and you're wondering, do I have a cavity? You have to decide, do I want to get my cavity checked out or do I want to risk going to prison? And so on and so forth. And I think you can imagine the kind of violence that has ensued against transgender Ugandans. So one of the actions that I think was very deliberate and very complicated was how the US government would approach our PEPFAR programming in Uganda. And by all accounts, and to the credit of the government of Uganda and the people of Uganda, PEPFAR has been a very successful program in Uganda. But how do you administer a program if there's a law on the books that is almost determined to increase HIV prevalence among key populations? So as Adrienne knows, because we had a lot of interagency meetings about this, one of the things that we did is we redirected as much of our support for PEPFAR work away from the government of Uganda and directly to Ugandan implementing partners who are committed to the principle of non-discrimination. And I think that was an incredibly savvy and very appropriate step because it ensured that the US government was not withholding support from HIV positive and vulnerable populations in Uganda. But what we were doing was looking to find an implementing partner that would commit to not undermining LGBTQI Ugandans' health. Adrienne, I have one more example I'd love to give, but I want to do a time check with you.
Very quick example.
Okay, fine. I'll just say, this work is not just about fighting the bad things, it's also about doing the good things. And one of the great successes of the past year has been passing the first ever intersex rights resolution at the UN Human Rights Council. Everyone, yes, you can applaud for this, absolutely. This is a really big deal. And for those of you that want to get into the details of it, I'll just tell you that it passed with 0 no votes. That has basically never happened on any issue related to LGBT issues at the UN ever. So it says that when we have a deliberate strategy and when we're really ambitious and we make our arguments, we can win.
Thank you. And Just in closing, all of the work that was talked about during this panel is happening with the clear and deliberate support of our Secretary, Secretary Becerra, and much of it's coming out of the executive order that Special Envoy Stern mentioned from President Biden, who has been incredibly clear about the direction that this administration would go when it comes in terms of LGBTQI plus equality. And we invite this to be a continued conversation after today, because a lot of the work that each of us talked about today has been able to happen because we've heard from many community members across the country who've shared about what's really happening in community in terms of LGBTQI plus people's access to care and services. So we invite continued conversations as this work continues as well. Thank you so much, and thank you to all of our panelists today.
Our next panel is something I think that's near and dear to all of our hearts in the community, and it's a panel on bullying, hate crimes, and the mental health impact on the LGBTQI plus community. We are really excited to have Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman, here today to lead this panel. And we have some really incredible panelists that will be joining us, including Jane Clementi, the co-founder and CEO of the Tyler Clementi Foundation, Tyler's mom also, and Sarah Bird-Sharps, the Senior Director of Research at Everytown for Gun Safety, Datavian J. Daniels, the Director of Partnerships and Development for Students Engaged in Advancing Texas, and also Molly Quinn, the Executive Director of Out Memphis. So please help me welcome Panel 3 to the stage. As the panel's coming to the stage, I spoke briefly to Dr. Delphin-Rittman before the session, and over the weekend I was so struck as a 53-year-old gay man who grew up in a rural area of North Carolina, and that experience of bullying that I had. And Viola Davis posted something on her Instagram this weekend that touched me so deeply. I wanted to read it before the panel, and I encourage you to find it yourself on Viola Davis's Instagram. It's a beautiful video with a chameleon, but it says, "Queer people don't grow up as ourselves. We grow up playing a version of ourselves that sacrifices authenticity to minimize humiliation and prejudice. The massive task of our adult lives is to unpick which parts of ourselves are truly us and which parts were created to protect us." With that, Dr. Delphin-Rittman.
Thank you so much, Lee, for that introduction, and just want to say welcome, everyone. Thank you for being with us for this panel, and thank you so much to each of the individuals that I have here with me. I also want to say thank you to IEA for organizing this important conversation, this important event. We know that this panel is so important, and I appreciate all of the work that each of the panelists here with me do every day to make a meaningful difference in terms of raising awareness. And so Jane, Molly, Sarah, Datavian, thank you for being here and for sharing your experiences. We all know that you know better than anyone else just the importance of LGBTQ individuals being supported and living in an environment where they have support and are valued and can thrive without stigma and without discrimination. And so know that I stand with you in supporting LGBTQ plus youth. And at SAMHSA recently, we've put forward a number of activities to be able to support LGBTQ young adults. And so I'm going to ask each of you a question, two questions actually in this panel, and then I'll end with a question for each of the panelists. And so Jane, I'm going to start with you, and I'm just in awe of the tremendous way in which you have turned grief into action. And can you please tell us a little bit about Tyler and the Tyler Clementi Foundation and the work that it does to end online and offline bullying in schools, workplaces, and in faith communities?
Thank you. It's a pleasure to be here. I use she, her pronouns, and I am the co-founder and CEO of the Tyler Clementi Foundation, as well as was introduced as Tyler's mom. For some who may remember, in 2010, Tyler made national headlines in the fall of 2010 when he started his freshman year at Rutgers University. It was there that his roommate cyberbullied him by live streaming him in a sexual encounter with another man and then posting about it on social media, really announcing a very private moment to the entire world, or at least the entire world in Tyler's eyes, I believe. And just thinking back, I'm really not sure what the whole purpose of what he was doing. Maybe it was to make himself out to be more cool or more popular or more connected or just being sarcastic or a sense of humor. But one thing I don't think he thought about was the great cost it would involve another human being, the great expense it would cost to another human being my son. And I don't even think he even tried to get to know Tyler, which is really heartbreaking. He didn't learn about Tyler's great sense of humor or his great curiosity and sense of adventure as an avid cyclist, or even his passion for music, or his great gifts and talents as an accomplished violinist. All that he got to know was by putting Tyler's email address into some kind of a special search engine, was that email address went to several chat rooms, gay chat rooms, and gay websites. And by that, he assumed one part of Tyler's identity to be all of who Tyler was, without any care. And he used that one component of Tyler's identity to humiliate him in front of his new dorm mates. It was as if Tyler didn't exist as a whole human, or at least someone worthy to get to know. And as Tyler continued to read the tweets on social media, Tyler's reality became very twisted and distorted. And unfortunately, Tyler made a terrible decision, a permanent decision to a temporary situation, because on September 22nd, 2010, Tyler died by suicide. And it is because of who Tyler was, we want to honor Tyler's legacy, but also not only raise awareness to the situations that impacted Tyler and the issues, but find actions and solutions to those issues. And most of who we are is to try to put an end, as you said, to online and offline bullying in schools, workplaces, and faith communities, because we believe that all of those components can add to someone's distress and shaming and humiliation. We have several programs online. I encourage everyone to go to our website, tylerclementi.org, and find out more about our Day One program and our Youth Ambassador program, as well as take our Upstander Pledge. So thank you for having me here today.
And thank you for being here and taking that experience and starting the foundation and working to raise awareness to reduce bullying. So thank you. So next, Molly, I'm going to go to you next. So can you tell me more about the ways in which Out Memphis engages LGBTQ plus youth with and at risk for behavioral health conditions? And in particular, I'm interested in knowing about the program that you have called Prism Care Navigation, which helps gender diverse youth find mental health support. And can you share a little bit about their unique needs?
Yeah, absolutely. And thank you so much for having me today. It's a real pleasure to be here and to talk about this incredibly important topic. My name is Molly, my pronouns are she, her, and I'm the executive director of Out Memphis. We are a 35-year-old community center located in Memphis, Tennessee. And for a long time, for several decades, we have, amongst our myriad services, have helped LGBTQ people of all ages get connected to mental health providers through referrals and education. In the fall of 22, we started doing some additional research in our community in conceiving of the program that you mentioned, which we call PRISM Care Navigation, in response to several measures that were happening in our state that were incredibly harmful to transgender and non-binary youth, first from our state attorney general and then from our state legislature. We spent several months talking to parents, to caregivers, to youth workers, to youth, and to our providers in our community about what transgender and gender diverse young people were experiencing. And we learned so much during that time. And I'm always struck and always talk about this really incredible, short, simple statement that I heard from one of our local providers of gender affirming care who, before Tennessee's ban, provided to 16 and 17-year-olds. And she told me that the prescription is the easy part, which certainly isn't to downplay the lengths that individuals go to receive gender affirming care. But what she meant, this incredible nurse practitioner in our community, meant that there is so much that happens to transgender adolescents between doctor's appointments, and that there is such a need for other kinds of support. And that includes mental health. It also includes all the other parts of life. So we launched this new program. We call it PRISM Care Navigation. And what the program does is meet each individual family of an adolescent who's anywhere from 12 to 17 and understands all aspects of where they are in their journey and how that links back to their health care and to their mental health care. So for some families, it starts with things like haircuts or name change services. For other families, it's about how to experience therapy for the first time. The part of country that I live in has a very low access to mental health services. There are a great number of barriers, and unfortunately, many people in my community don't have a lot of exposure to behavioral health sector in general. So a lot of what we do is actually meet with youth and families and tell them what they can expect at therapy, which is a trusted and terrifying experience for young people at the same time. And we also have seen in my community that there are many socioeconomic barriers to mental health intervention. So part of what our program does is say, are you seeking name change? Are you seeking a haircut? Are you seeking transportation access to get to your therapy appointments? Does your family need food or housing security, stability, so that you can focus on your mental health? We really heard from our community that there was a need for connective tissue between providers and families. The other piece that my program seeks to do and has been very impactful so far is to educate our local providers. As there have been so much harmful rhetoric in our communities about transgender youth, we've seen, unfortunately, a lot of providers not understanding where policies live and where things are moving at all times, and also absorbing and experiencing some of the misinformation about transgender healthcare. So a lot of what we've taken on as our responsibility is to ensure that the mental health providers in our community have the best tools and information before they take on the incredible responsibility of uplifting our LGBTQ young people.
Thank you. Thank you for the work that you're doing. And I love that you take a real person-centered approach and that you're meeting families and communities really where they're at in terms of raising awareness and addressing their individual specific needs. So thank you. So next, Sarah, I'm going to go to you. So there's a fact sheet on the Every Town for Gun Safety website that notes that from the Pulse shooting in Orlando in 2016 to youth suicides and anti-trans violence across the country, LGBTQ plus communities has suffered terribly. What are some key steps that can be taken to reduce the likelihood that LGBTQ individuals experience gun violence?
Thank you. Thanks for that question, and thanks for having me here. It's great to start off Pride Month this way. And so my name is Sarah. I use she, her pronouns. I've been leading the research department at Everytown for about 5 years, and we have a group of about a dozen amazing social scientists who are trying to fill in the many gaps in research that we have many unanswered questions in this field, and to understand sort of why and root causes, and also what are the most effective solutions. So that's what we've been working on. And I'll be the one who's giving you some stats and some wonky stuff. So I want to start out in answer to your question to be really clear that it's true that LGBTQ plus youth do face are disproportionately victims of violence, but it's not because of their identity. And I think that's really important to understand, right? It's because of the discrimination that they face. It's because of the daily toll of harassment and bullying that wears down their physical health, and makes them both, takes a toll on their physical health, but also makes them more likely to be harmed. So that's kind of how I want to start out, by saying it is not because of their identity, and I think that's really important. And I think I want to talk maybe about two areas where LGBTQ plus youth are particularly disproportionately impacted by gun violence. One of them is in firearm suicide, and the other one is in transgender murders. Not the most uplifting topics, but I'll try to be uplifting in terms of the solutions. So in terms of gun suicide among young people, the Trevor Project recently did a really good survey this year with LGBTQ plus youth, and they found that nearly 4 in 10 of the people who responded to the survey, and there were 18,000 young people, seriously considered suicide in the past year. And that is a really sobering statistic. And among teenagers, half of the suicides are with a gun, and almost all of the children who get access to a gun get it from their parent or from another relative. So that leads us pretty quickly to what are the solutions. So the first most important solution is that every household with firearms needs to securely store those firearms. And that means locked, unloaded, and separate from ammunition. And, responsible gun owners know that, but too often, they keep one of their guns, available. They think they're going to use it for self-defense. Tragically, often that turns quite bad. So locking guns is the way to make your entire family safe, and particularly for young people. And the second area, or the second step that's really important, is something I'm not going to talk much about because you all who are working on the ground can talk about it, but it's accessible and affordable mental health opportunities for LGBTQ plus youth. And then the third one I am going to talk a little bit about because it's a policy. And I think that we need to understand we need actions at every level, the local, the state, and the federal, programs and funding and policies and laws, et cetera. So the third one is waiting periods. So in 13 states in the US, there's a buffer of time put between wanting to purchase a gun and being able to access that gun. It ranges in states from like 3 days to 10 days, but the research shows that that buffer of time can really save lives. So for those of you who are doing advocacy and thinking about what can be done, waiting periods, our research shows incredibly effective. And they put a stop between somebody who's in a suicidal crisis and taking an impulsive action that can never be undone. So that's the first area where LGBTQ plus youth are disproportionately impacted. The second area is in terms of trans murder of transgender and gender expansive people. And this is an area where there's hardly any research, hardly any statistics. So we've been actively, setting Google alerts to sort of collect this. And what we found is that every year, over 24 trans people are murdered in the US, 3/4 of them with a gun, and over half of them are under 30. That's an issue that is not talked about enough. People don't realize what's going on, and they don't understand what you can do. And I want to talk just very briefly about 2 things that can be done. One is these transgender murders aren't spread evenly across our country, and I'm sure people can imagine why and what's going on. 45% of gun homicides of transgender people are in the South. The South has, yes, higher rates of gun ownership, yes, fewer protective gun safety laws, but it also has people in positions of power who are speaking, whose rhetoric and whose laws are discriminating against trans people. And that rhetoric and those laws are having tragic, lethal consequences for trans people in this country. And the second area is something that I think a lot of people don't really know much about, which is about hate crimes. So federal law bars felony convictions, or people who have been convicted of felony from having guns. But many hate crimes are not considered a felony in some states. They're considered a misdemeanor. And that means you can commit a violent act and you can still buy a gun, you can still possess a gun, you can still be armed. So half of U.S. states have extended hate crime laws to impact access to a gun. But still, there's 69 hate crimes a day that involve a firearm. And many are driven by hate based on gender identity. That's using FBI data. So we have a long way to go in terms of some of the laws that research shows us can reduce the toll of gun violence on transgender people.
Thank you so much, and I appreciate that you shared the data, which is very much a call to action, and that you outlined really strategies at the local, state, and federal level. We know it'll take all of us to make a meaningful impact here, so thank you. So Datavion, thank you for being here. And so at Students Engaged in Advancing Texas, or SEAT, you play a pivotal role in fostering collaboration and synergy among youth advocates, policymakers, and community stakeholders. What collaborative actions has SEAT engaged in to address the mental health among LGBTQ+ youth?
Thank you for the question, first of all. Good morning, everyone. Thank you for saying back. My name is Datavion Daniels. I'm a rising senior in high school in the Dallas-Fort Worth area. I live in Texas, and we have a lot of issues. And, SEAT came along as kind of a bandage to those issues until we can, work together to actually make impactful and long-lasting change. So I actually want to start with something from Dr. Alexis Pauline Gumbs. What's queer is that we're still here, and that's specifically the case in Texas and across the United States, honestly, because when we look at these systems that have been put in place, they were never made for us. They were never made for people of color. They were never made for LGBTQIA+ individuals, and they were never made with young people in mind, and that was part of the problem for us. And we saw, our own awakening as a way to actively engage other stakeholders, other students, and get them out there and get them active around the issues that matter most to them. And when it comes to the actual policy aspect and LGBTQ and mental health, I think we have to really recognize the intersectionality of those two very disadvantaged and highly politicized topics in this country right now. And when it comes to young people in this movement, I think a part of that is actually listening and listening to the young people and taking what they have to say into account when it comes to making policy decisions. And in Texas, we didn't have enough of that, so we wanted to do something about it. We organized around it, and we've been organizing around it since March of 2023, and we've been relatively successful. Some of those instances were actually using some of the systems in place here. OCR. In Katy ISD, there was a gender policy passed by a very much radical school board that basically said, if a student is queer or anything that is not homosexual, the teacher is an obligated reporter of that. Now, who in here thinks that's right? I saw no hands. I'll just say that. And it's a problem. So we wanted to organize around that, and we did. And we drove a media campaign using the OCR complaint as our catalyst for that change. And that actually drove up so much media attention that, they kind of dialed back on it, and now they're in a position where there's an open investigation by the OCR because of that policy that was passed and because of the students that it affected directly. And not to mention the mental health burden that policy caused. Over 20 students outed by people who they felt, were their trusted caretakers in an academic space. This is where students come to learn. This is where students come to grow, become better members of society. But, politics got into the classroom, and politics got into the way of teachers actually being teachers. So they were outed to their parents, and that's horrible. So we drove a really successful media campaign around that, and we got that OCR complaint opened up, and now we're hoping, for some more change. But that's not, that's a one-off instance of it. But there are instances like this all across the country and all across Texas. We saw it in Conroe with their copycat policy of the same thing that Katy did. We're seeing it in Keller with all of their pronoun Why does that even have to take place at a school board meeting? But I digress. You know, pronoun conversations and pronoun policy, it's idiocy, and it divests from what we're actually here to do. We're here to learn and become more accepting and an equitable society, and we can't do that when division is being sparked and driven by political motivations and political agendas. And that's what we're seeing right now in Texas, and that's part of the problem. But to digress and get back on topic to your question, we've been engaging students, and I think that's where it really starts, at the most local grassroots level, getting the students active, saying, hey, if you don't like this happening to you, or you don't like what's going on in this district, you can use your voice as a catalyst for change for those students whose voices have not yet been amplified. And that's really where it lies with SEAT, and that's really what we've tried to be, achieving, and we're really excited to keep that momentum up and keep working with institutions like OCR to keep filing those complaints, to keep bringing, limelighting these situations, and keep the change flowing, because if we don't, we've seen it before, and it's going to continue to happen, and it's going to happen again, it's bound to, when we don't stand up for what we believe in, and when we don't stand up for the rights of those who, whose voices have not yet, gotten the limelight or the attention that they need, we see that their rights are trampled. And, people always ask, why are you all engaging in LGBTQ, this, that, and another? Because we can, but that's not really it. It's because, this matters, and people matter, and people should be seen equally, no matter who they are, and no matter where they come from, or no matter, their gender identity, or no matter their sexuality. And that is what we're trying to do. We're trying to break down those barriers.
Well, thank you. Thank you just for that dedication and passion. And I love that you talked about, you're starting with students, you're working to engage students, but you're also working to change policy and change systems. So thank you for that, because that makes a difference. So I'm going to continue on. So Jane, HHS at StopBullying.gov website has resources to help you safely upstand to bullying. Can you tell me more about being an upstander and how upstanders can help to reduce mental health impact of bullying among LGBTQ+ youth?
Sure, thank you. And I'm so glad to see that other organizations are having the same messaging that we have also, because we first started being aware of the fact that there were many people that saw what was happening to Tyler, that just stood out to us as we learned about what was happening at Rutgers. And we just learned, as I started doing the work that I'm doing, that was not an unusual phenomena, that in almost all bullying situations, there's not only the aggressor and the target, but there's also bystanders. And that's why I'm so passionate about turning those passive bystanders into active upstanders. One of the things that we learned was that if someone intervenes in a bullying situation, that in almost 60% of the time, the bullying situation will end or stop within 10 seconds. So it really has a lot of power to stand up and intervene. But as a non-confrontational person, I needed options. And that's what we've kind of developed at the Tyler Clementi Foundation, so that it's not only about intervening or interrupting the bullying. Sometimes it's about the interruption could be just coming beside the person being targeted and walk them away out of the situation. Or it might be that you're just hearing verbal bullying, but there might be verbal bullying of homophobic or transphobic or racial slurs, and it might be among people you know, it might be even among friends, and just calling that out, saying that that's not cool, using those words in this space. So sometimes it's very simple, and it doesn't have to be confrontational, but we always want people to be safe, and we don't ever want it to escalate into a physical violent situation. So we also strongly encourage all youth to report the aggressive behavior to a trusted adult, to know who your trusted adults are in the space that you're at school. Who are the teachers, that you're not outing someone, or you're not bringing passing rumors. It's not rumors, or it's not being a tattletale if it's for someone's safety. And we always have to make that clear. People sometimes won't repeat things because they don't want to be the tattletale. So that's very important. And also one of the things that we thought had not happened with Tyler is it's for someone to speak up to the person being targeted, to interact with that person so that they know where their resources are, they know that they're not alone. It's so important to feel the community and friendship. So we definitely think that there's many ways to approach being an upstander, but I also think being an upstander is further than just a bullying situation. I think we need to use our power, because it's all about power, to make sure that we get to the polls to vote and we change policies, and we don't make sure we don't have legislators that are continuing to put out anti-trans legislation or the Don't Say Gay bills. And one of the things that I'm really upset with is the book bannings that are happening across the country, because there's so much power in knowledge and in sharing stories, and our stories cannot be silenced. It's so important not to silence our stories. And so there's so much more. It just grows and grows and grows. And I'm just so glad to see other people as well as Tyler Clementi Foundation and HHS all promoting upstander behaviors. I hope you're all upstanders and you can go take our pledge at tylerclementi.org if you're so inclined later today. Thank you.
Yeah, thank you for that. And it's such a powerful message, that we can all play a role, that we can all stand up one way or another and make a difference and work to intervene. So thank you. So Molly, SAMHSA has worked with Dr. Caitlin Ryan and the Family Acceptance Center and project for a number of years. Last year, we began an LGBTQ+ family counseling and support grant program. Can you tell us about how your organization works with families to support and affirm LGBTQ youth and children?
Yeah, absolutely. I'm so glad for this question. It allows me to bring up some of the things that I think are most important in our community to mention. One is that I want to start, since I know that hope has been one of our themes for today, that I've seen at my organization and in my community, like a true sea change in the last 5 or 6 or 4 or 5 years in parents of LGBTQ youth becoming ferocious and courageous advocates for their kids in a new and different and really powerful way. We have so many parents in my program who were not necessarily politically engaged, did not necessarily come from accepting communities, may not live in accepting parts of our region or our county, may come from faith communities that perpetuate a lot of homophobia and transphobia, but have taken LGBTQIA+ equity as their mission on behalf of their kids in a way that was so different from a decade ago, so different from when I was young. And I think that those parents need to be centered, they need to be uplifted, and more than anything need to be taken care of by our communities, that their needs need to be met. As we have grown and deepened our work in understanding how families need holistic support, I've really come to understand how much parents in the South are dealing with right now. I'm very glad to share space with you and your organization, because in my state, over the last several years, the teeth of political rhetoric and fights around young people center on gun violence and on LGBTQ issues. And those two issues are not happening in a vacuum. They're happening to the same schools and families, the same communities. And I think there are so many parents that are trying to understand the best ways to connect their kids to healthy and well societies and to healthy and whole environments, and have so many different obstacles. In my state, we're dealing with so many new and changing and evolving policies, and unfortunately, a lot of our anti-LGBTQ and anti-trans policies in Tennessee focus on schools, and they focus on young people and parents. So the question was, what are we doing in my organization, in my state, to meet these parents and youth where they are, and to help foster better and more positive relationships amongst families? The first and most important thing, I think, with supporting the healthy relationships between youth and the adults that care for them is education. Rhetoric has come up, I think, by every one of our panelists, and one of the sad and true things happening in my community is that the harmful rhetoric, while easy to debunk when you have the facts, is really quite pervasive amongst the caregivers and youth workers in our communities who may not have access to other kinds of information. So we really believe that communicating with parents, caregivers, and youth workers about what LGBTQ youth are going through and what their needs are is critical work. I also think that it is so important for adults in the lives of LGBTQ youth to have secure, safe places to ask their questions that do not put the burden of education on LGBTQ youth themselves. And I think as professionals and as adults in this community, that's part of our responsibility, is to create those environments and create those opportunities for adults to get educated. I know I can speak for myself and say that the youth in our program are often my teachers of what their needs are, and I think that's beautiful and fabulous, but I also want for young people to be able to be young, and not all of them, while your work is amazing, I also want you to be able to just be 17 and do the things that you can do, the silly things that I did, and that's part of the responsibility that we have. So my programming focuses in many, many ways on educating parents and providing them the fundamentals of understanding what's going on with their youth and their kids and the kids in their communities. We also do a good amount of providing financial assistance and other social service supports to parents of LGBTQ youth, as I mentioned before. So we've seen in many instances, and I know food security came up this morning, which I think was so important in understanding the context and experience of equity and rights, is that when basic needs aren't met, our fights towards equity are held back for everyone. So that's a lot of the work that we do. The last thing that I'll say about supporting families is something that I share with two groups of people that I meet with a lot. One is the parents of LGBTQ youth, and the other are LGBTQ adults who are also parents. I think that when we have a positive, healthy, comprehensive understanding of queerness and equity and accepting in classrooms and church culture and in neighborhoods, it benefits all young people. Having adults who are educated and have keen understandings of youth autonomy, youth equity, create better environments for all youth. It is not just about meeting LGBTQ youth with the direct needs that they need, but about creating bigger, more expansive, and more compassionate culture for young people across the board. Thank you.
All right, thank you so much. I know our time is winding short, but I have a couple more questions. And so real quick, so Sarah, we know that in the wake of the Pulse and the Club Q shootings, SAMHSA provided emergency response grants. Can you speak to the importance of the ongoing trauma focus and the importance of having a trauma-focused approach to the support of gun violence victims?
Sure, and I would start out by saying what I have learned in this field over the years is that any injury or death from gun violence is a shock, the suddenness of it, right? There's no, that is a given. And trauma comes for those who are directly involved, for their families, for their communities. It ripples out. So that is a fact. And when a shooting involves LGBTQ plus people, especially ones that are highly publicized, like the two that you just mentioned, the psychological harm can be done to an entire group with a shared identity, not just the immediate loved ones and the family and the local community. The ripple is really, really wide. And so, and it sort of sends a message to these people that they're not safe. And I'm sure that many of you know people who, after these, mass shootings, were deeply impacted, even though they were, hundreds or thousands of miles away. So the support to gun violence survivors needs to be all-encompassing. It needs to be physical and mental support, but that's not where it ends, right? It needs to be legal support, it needs to be financial support, food support, the whole range of things. And often it's long-term, lifelong, or quite a bit of time. And one of the And I wanted to talk a little bit about the Trevor Project survey again, because I thought they asked a question about, are you interested in, mental health counseling or therapy or support? And nearly every kid said yes. And then they asked why, are you getting it and why are you not getting it? And the kids were very clear. They have a lot of fear about whether the therapist or somebody's going to tell the police, whether they need to get permission from their parents. So it was really clear that that's a huge unmet need. And an area where we all have a lot of work to do, sort of locally and on the way up. And I just want to finish by saying that for me, I think one of the most gratifying parts of my work is when I work with survivors. Every town has a survivor network of about, maybe 3,000 people who've taken the very brave and courageous choice to turn their pain from an unspeakable tragedy in their lives into action. And they are incredible. They are articulate, they're brave, they're doing social media, they're speaking to legislators, they're attending lobby days, they're, out there, and it's not easy. And they're also receiving support and strength from one another. And that work is so important for people who have had this personal experience to be able to articulate what they need and what needs to happen.
Thank you so much. And so, Datavian, so the final question, I know you indicated that you are always working towards a future where mental health is not ostracized for individuals from the LGBTQ plus community. Can you say, and can you speak to LGBTQ youth, or what can you say to LGBTQ plus youth about the fact that having a mental health condition does not need to be ostracizing? And so the last couple minutes go to you. Thank you.
All right, so there are two sides to that coin. There's what I have to say to the other young folks out there, and there's what I have to say to the older folks, because it's intergenerational, all of the work that we do. There is a deep hatred being sown in the country, and it's creating it's a culmination of things. It's, the policy that's passed, it's the book banning, it's all of these things coming together that's going to create a domino effect, and is creating a domino effect that's leading to the detriment of mental health, specifically for LGBTQIA plus individuals and other individuals all across the country, and it's radicalism, it's extremism, and it ultimately, we can do everything in our power to continue to uproot this hatred and, try to progress forward, but it ultimately takes all of us. And, to the other queer youth out there, all I have to say is show up if you can. And, use your voice as your power, because it is your power. We all have, rights in this country, and it's the way that we utilize them that can ultimately make a difference. We are all so separated in all of our different facets of work. Gun policy, gun reform policy, youth who are experiencing this right now, and we work with youth directly in Texas. But I think it takes a stronger network and a stronger, like an intergenerational partnership, like I mentioned, in order for there to actually be actionable change and for us to see the change. Because if we don't, we get into this defeatist mindset that a lot of young people are experiencing. That's why suicide rates are up. Not because, mostly because of all the crap that's going around, but all of the things that go along with that, and all of that has to stop ultimately, and we have to do everything in our power to make sure that stops. But us working alone in Texas, like me, or in Tennessee, it doesn't work. We have to work together. And to the adults out there, I just say, be a catalyst for the other young people in the room. Be a catalyst for their own advocacy and their own empowerment. And, just do what you can. And, activism is not the big grand gestures like a march on the Capitol or me getting up here and speaking. It's whatever you can do to make a change. And that's all that matters. So if we keep doing that, then, we're going to see the progress. And it may take a while because, this, like I said, this system was never originally created for us. So we have to work against it, and we're working against a clock constantly, no matter who's in office or no matter who has power, but we're always working against a clock, and we have to be unified in order for all of that to change. So that's all I have to say.
Thank you so much. Thank you so much. And I love that you're stressing an intergenerational approach and your message to young folks. Stand up and use your voice, use your power. And so that is our time. And so give it up for our panelists. So appreciate you all being here. Appreciate you being here and sharing your experiences. So thank you.
Good afternoon and happy Pride. I understand that I am between you and the end of the summit, which just based on the agenda alone seems like it was incredibly rich and also covered a lot of really important stuff. So I won't take long. I'm just here to provide a couple of final words. Before I do, I just want to thank the last set of panelists. What an inspiring conversation to be able to witness, especially to Tavion. Thank you for your ending words there, giving us all something to aspire to. So again, happy Pride. I appreciate the opportunity to be able to speak with you today. My name, as you heard, is Jamie Citron, and I am the Principal Deputy Director of the Office of Public Engagement. In early June of last year, as waves of anti-LGBT legislation swept state capitals across this country, President Biden threw open the gates of the White House to hundreds of LGBTQ+ families of all shapes, sizes, and kinds from all 50 states to celebrate Pride. It was a little warm, but the sight was one I will never forget. Our community defined by our diversity and our joy, surrounded by others just like us, enjoying that most American of activities, a summer picnic with lawn games and pizza and also Betty Who. Is this the most revolutionary thing that President Biden has done in the last 3 years for our community? Absolutely not. But it does highlight who he is and what he stands for. A president who sees and celebrates us, and a father and a grandfather who sees beauty in all families. President Biden is fond of reminding us that America is the only nation in the world founded on an idea, that we are all created equal and that we deserve to be treated equally throughout our entire lives. He says, and I agree, that we have never fully lived up to that idea, but we have never fully walked away from it either. As others work to divide our nation and use us in particular as a wedge, President Biden reminds us that our diversity is our strength and that the idea of America belongs to one and all. Most importantly, he reminds us that it is our responsibility collectively to protect and shape the future of this great nation for many generations to come. From signing the Respect for Marriage Act, reversing the ban on transgender service in the military, and launching a new nationwide crisis hotline, 988, with a dedicated service line for LGBTQ+ youth so they can speak with affirming counselors, President Biden has shown that we are at the heart of his America. But we know that there is much left to do, and it will take all of us to do it. To the advocates and activists in the room, of which I see many, many familiar faces, thank you for being here. We thank you for your partnership and your pressure to keep driving us towards that more perfect union. And to our hosts, thank you for the extraordinary work you do every day on behalf of LGBTQ+ Americans. I started my government career in this building, in the Office of Faith-Based and Neighborhood Partnerships, so it holds a very special place in my heart. Since the start of the administration, no agency has been more on the front lines of protecting, codifying, and expanding our rights than HHS. I look forward to seeing the work that we do together in the coming months and years ahead. So with that, I wish you a happy and a safe Pride, and I thank you again for your time.
Awesome. Thank you so much, Jamie. Thank you for being here on behalf of the White House. I'm actually the one standing between you and leaving, so keep it very brief. Just one more thank you from the HHS family for being here. We are so happy to kick off Pride with all of you. Please reach out to IEA if you have any questions, any follow-up. We have a lot of stakeholder briefings on the great work that you heard about, and we are really looking forward to celebrating the rest of the month with you. Thank you all. Take care.
Produced by the U.S. Department of Health and Human Services.